Good evening. Welcome, Titial sir.
Good evening to all of you. Sorry, I got stuck to another webinar and not come out from that.
Thank you, sir. Thank you. Just we are initiating in it's another few seconds.
So we are live.
Okay. So good evening, friends, and welcome to this 22nd episode of All India Postgraduate Teaching Program, which is a new initiative from ARC. There were lots of postgraduate teaching programs we are getting offering very different aspects of teaching program. We wanted, and so we decided to have things which were uncovered in other PG programs like case presentation, journal clubs, OSCEs, and didactics on topics which are not really comprehensively available at a go in a textbook. For example, in the last episode, we had two short cases on retina. Today, here we are on the 22nd episode of this series, and this is the fifth journal club. And in today's journal club, it would be presented, the first article would be presented by Dr. Neetu Daniel, who is a secondary DNB final year resident at Sankara High Hospital, Coimbatore. And the second article will be discussed by Dr. Abhijay Luthra, who is a DNB resident at Shroff's Charity Eye Center, New Delhi. Special thanks to the mentors from Shankar, Dr. J.K. Sankara Hospital, Coimbatore. My also special thanks to the mentors of Shroff's Charity Eye Hospital, Dr. Shaninder Sabharwal, who is the Director of Public Health Network, and Dr. Julie Pegu, who is a Consultant Glaucoma and Cataract Services at Shroff Charity Eye Center. My special thanks goes to the discussant, especially Dr. R. Venkatesh, who is Chief Medical Officer at Arvind Eye Hospital, Pondicherry, Dr. Arup Bhaumik, who is a Senior Consultant at Disha Eye Hospital, Kolkata, and a dear friend, if I dare to say so, Dr. Jeevan Titial sir, who is the Chief Center of Ophthalmology at AIMS New Delhi. Discussant Dr. Venkatesh, Dr. Bhaumik, and Dr. Titial, who are so busy people in their own respective field, but have found time for my young postgraduates. We are very proud to say that this postgraduate teaching program is having a great viewership. In fact, the last episode viewing for the case was almost 1800, with the YouTube count of 821, Facebook of 560, and web on 372. And this happens within this count is of 45 days. So in total, if you look at it, in a month, we are getting a viewership of close to 2,500 to 4,500 per episode, and we are very proud to boast about it. So without much ado, now it's my time to get going. And I would request Dr. Neetu Daniel, who is a secondary DNB final year student at Sankara Eye Hospital, Coimbatore, to share her screen and present her article. And I request all the discussant as well as mentors that when the PG is presenting, you can interrupt her. You can start discussing at whichever stage you find. The PGs are going to present. Cumulative time for them is about 10 to 12 minutes to present. 20 minutes is for discussion. But that discussion can be in between as well as later on, whatever you prefer to do. Over to you, Dr. Neetu. Can you share your screen, please?
Yes, sir. So 1 second, sir.
Sure.
Hello, sir.
Yeah, we can see your screen. Can you have a sharing full screen now? Presenters mode.
Yes, sir.
Yes. Great. We can see your screen and you are audible as well. You can go ahead.
Yes, sir. So good evening, my seniors and my colleagues. Today, thank you ARC for giving me this opportunity. Today, I'll be presenting a review article under the mentorship of Dr. J.K. Reddy sir and Dr. M. Prabhushankar sir, Shankar Eye Hospital, Coimbatore. So I'll be presenting a review article on toric intraocular lenses, which is an evidence-based used by Michael Goggin, published in Clinical and Experimental Ophthalmology in the year July 2022. So coming to the history, so first initially we had PMMA toric IOLs. So that required a large incision size and a scleral approach for insertion, but had limited success rate. And then came silicone toric IOLs, but they also required a sizable incision, but they can be folded for insertion, but they had poor rotational stability. But the acrylic toric IOLs, which are made up of highly compressible material with strong structural memory, so the astigmatic benefits of smaller phacoemulsification can be utilized. And in aphakic eye, it's mostly the corneal astigmatism. Whereas in phakic eye, both cornea and lens contribute to the astigmatism. So the full refractive correction of the aphakic eye includes not only the correction of the profound spherical error, but also the correction of the corneal astigmatism as well. So in this figure, we can see that the loss of the unaided visual acuity with increasing astigmatic error. It is influenced not only by the power of the astigmatism, but also its orientation. And the question comes, what is the minimum requirement? That is, what is the lower limit, minimum requirement for toric IOL implantation? So it happens when the predicted remaining astigmatism is less than, it should be less than the predicted is less than the predicted post-operative corneal astigmatism. Hence, the patient will receive a refractive benefit. And coming to the pre-operative management, so we can measure the corneal astigmatism by automated keratometry, manual keratometry, corneal topography, and the Scheimpflug imaging, which measures both anterior and the posterior cornea and gives the total corneal data. And also the gold standard being the partial coherence interferometry device, that's the IOL master. And when it comes in optometric practice, the corneal
Can I interrupt, Dr. Neetu?
Yes, sir.
So if you look into this introduction part, because whichever article we go through, especially the review article, the introduction has to be absolutely precise, which gives you the idea what has happened, what is going to come in subsequent review. I think you talked about, this article talks about the minimum range of astigmatic correction, which is correct. But there it doesn't mention the new requirement with the now we have a multifocal lenses, trifocal lenses. That is the one which is initiated to decrease the the range of astigmatism to be corrected. Earlier we used to say 1.25 cylinder.
Yes, sir.
Now it has come down less than 0.7 also. So
Yes,
that line should have been there. It's because of a requirement of these presbyopic correcting IOLs, we have to get back to the minimum possible astigmatism. If that line would have been there, this introduction would have been absolutely fine. Do you understand that point?
Yes, sir. Yes, sir.
Yeah, go on, please.
Yeah, so in optometric practice, we say that the corneal astigmatism should not be overcorrected and the axis should not be flipped, because this results in a visual discomfort from the meridional magnification and the unusual distortion of the visual environment caused due to this overcorrection and flipping of the axis. But when it comes to toric IOLs, these are not prone to these aberrations. So the overcorrection is indicated if it leads to less remaining refractive astigmatism rather than undercorrecting. Then coming to the calculation of toric IOL cylinder power. So whatever measurement we have taken, these data are fed into the toric calculators, but there is always a test variation that is seen with all the devices. So in order to prevent the error and for consistency, we should compare the data from at least 2 independent measurements. And for the accurate power and access prediction, we should include the surgical induced astigmatism and the posterior corneal astigmatism. So when it comes to the surgically induced astigmatism, one way is by calculating the vector difference between the pre and the post-operative corneal astigmatism. And an alternative is to calculate the average flattening on the incised meridian, which is again calculated by the vector analysis. Vector because it has both, astigmatism has both magnitude and direction. And the third is by applying a theoretical value, that is 0.1 diopter induced flattening on the incised meridian. Then in extracapsular cataract extraction, where the incision length is almost 11 mm, where we have an unpredictable surgical induced astigmatism. And in sutured incision, again, the astigmatism is unpredictable. But the prediction will be easier if you reduce incision size to a point where there is no measurable change occurs, that is equal to nearly 2 mm clear corneal incision. But the routine phaco machines, we require an incision of at least 2.4 mm or slightly larger, which is again astigmatically active. And another entity is the posterior corneal astigmatism. So in the posterior corneal astigmatism, we know the anterior surface of the cornea is convex and the posterior surface is concave. So this anterior and posterior gaze contribute to the total corneal astigmatism. And the steeper meridian of the posterior corneal astigmatism is mostly vertical and it acts like a concave lens. That is, it contributes to around -5 to 6 diopters. In with the rule astigmatism, the posterior corneal astigmatism will decrease the total corneal power that we tend to overestimate, and vice versa, that is, we underestimate in against rule astigmatism. So the cutoff for considering the toric IOL is lower in against rule astigmatism. And we have various online toric calculators. So these calculators require keratometric data, combined anterior and posterior corneal data, anterior chamber depth, and axial length. And we have some calculators provide automatic application of population-based adjustment. And they will incorporate an estimate of surgically induced astigmatism. And we have calculators like Barrett, Kane, Assad, Gauguin. And this is one of the Barrett toric calculators where you can freely access online, where you can feed in all the data like the flat K, the flat axis, the steep K, the steep axis, and we'll get the recommended IOL power and the cylindrical IOL power, the plane, and the target refraction. So the Barrett always has provided a method of combination of information from several devices into one set of composite data. And now coming to toric IOL overview, that is the toric IOL comes in a refractive steps of typically 0.5 diopter to 0.75 diopter with upper range between 6 and 9 diopter, that is depending on the manufacturer. So the stepwise progression of the power imposes the concept of this non-zero target. So while implanting the spherical IOLs, rarely is a predicted outcome emmetropic, even that is what we desire. So the non-zero astigmatic target is necessary when calculating the IOL cylinder power, even if the perfect axis alignment is achieved. So, and both the biomaterial and the IOL design is an important factor in toric IOL stability. So when it comes to the design, the loop haptic IOL prevents early rotation, and the plate haptic IOLs provides a long-term stability, but the early postoperative rotation is more common with the plate haptic IOLs. And when we look into the biomaterial of toric IOLs, the haptic material, if it's made of acrylic, it has got the best stability, and the least stability is found with silicone IOLs. And when we look, then the surgical techniques. So the three main cardinal features are the method of identification of the intended meridian or the placement of IOL, and use of an incision with predictable corneal astigmatic effect, and finally the accurate rotational placement of IOL in that particular meridian. And the axis identification, we all know that in a recommend position, the cyclotorsion occurs. So the identification should take place always in the upright position. Also, the local anesthetic effect can alter the position. So before the local anesthetic and an upright position, we should identify the axis. So the pre-operative manual marking is done immediately prior to surgery. That is, we mark a place to identify a typical meridian, that is the horizontal or the vertical. And all toric IOLs have the least powered axis on the IOL marked on the optic of the IOL, and this particular axis is placed on the most powered corneal meridian. And the marking is done by naked eye instruments or smartphone tools. So we have the toric bubble marker, the Mendes ring, the Grather half circle marker, and the Oshner-Newman corneal marker. So this is a slit lamp video of a slit lamp marking, manual marking, where the patient is seated on the slit lamp and the slit beam is rotated to the desired axis, and we mark 2 points inside the temporal limbus and 2 points inside the nasal limbus, and finally the aligned toric axis will be bisecting the center of the cornea. And we have also preoperative digital marking, where the automated image guidance system uses preoperative program data to identify the appropriate corneal meridian, like the Videon system and the Callisto eye system. So intraoperatively, these images are matched using multiple reference points on the conjunctiva, limbus, and iris to create a digital overlay of the preoperative image and the live surgery image, like a fingerprinting. And this is again, hello.
Yeah, we can hear you. Go ahead.
Yeah.
Carry
This
on.
is a Callisto size eye system. This is again a eye tracking navigation where the digital marking is done, but also no clinically relevant advantages were found in terms of unneeded distance visual acuity. So regarding the intraoperative aberrometry, it's an Alcanora system. It's a non-invasive, non-contact integrated intraoperative wavefront aberrometer system. It uses real-time intraoperative optical measurement, which matches the IOL axis with the axis of the astigmatism using refractive data gathered and processed by the system. Especially in low astigmatism, this intraoperative aberrometry outperforms the preoperative formulas. And coming to the surgical method, the incision, that is a surgically induced astigmatism of any incision in or near the cornea is proportional to its arc length and inversely to its distance from the center of the cornea. So the clear corneal incisions are placed on the horizontal meridian. They are less astigmatically active than those placed on the vertical meridian because the limbus is oval, horizontally oval, and the scleral incisions are less active. Whereas a longer incision at all sides, it is more active, and the astigmatically neutrality is achieved at about 2 to 2 mm in the periphery of the clear cornea. Above this threshold, the effect is variable but still predictable. And capsular recess should always be well centered, well sized, providing 360-degree overlap of the optic by the capsule. And the size of the capsular recess is adjusted to the IOL optic diameter, and it ranges approximately 4.5 to 5.5 mm. And the femtosecond laser assisted capsulotomy also creates a precisely sized recess. Then regarding the toric IOL implantation, so after phacoemulsification, the empty capsular bag is filled with a viscoelastic followed by the insertion of the toric IOL. So using a clockwise rotation, a gross alignment of the toric IOL is achieved while its haptics are unfolding. So this is a video showing the toric IOL implantation. So we implant the toric IOL in such a way that the marks on the toric IOL should correspond to the marks on the cornea, which is marked preoperatively. And it's absolutely vital to do a thorough visco wash to prevent any misalignment or malrotation. And the capsular tension ring. So the recent studies show that no improvement of toric IOL stability after additional implantation normal eyes. So the usage of CTR during toric IOL implantation may be reserved for special situations like higher myopic eyes and sonal instability at the time of surgery. And the post-operative assessment and management of toric IOLs. So the rotation stability of the IOL must continue for expected refractive results. The malposition of the toric IOL in post-operative period, it can be either due to erroneous intraoperative placement or a post-operative rotation. The erroneous intraoperative placement can be avoided by a good preoperative measurement and a good surgical technique. Whereas a post-operative rotation happens in myopic eyes, they are more at risk for this post-operative rotation because the capsular bag is sufficiently large. So there is a poor contact between the IOL haptic and the equator of the capsular bag. And the post-operative rotation can also occur in small eyes as well, but it's less commonly. Then how do we identify a toric IOL rotation or a malposition? So we can examine with a dilated pupil and the failure to achieve the expected, and also when there is a failure to achieve the expected vision post-operatively. Three causes of astigmatic refractive surprise we encounter is when the IOL is off axis or when there is an incorrect IOL cylinder power or a combination of both. So the analysis of the problem is done when a reasonable manifest refraction can be taken. That is usually when the patient comes 2 weeks post-op. And if the power is at fault, we opt for a lens exchange or a secondary IOL or an excimer laser surface ablation procedures. Or when there is an isolated only axis error, it can be rectified by the rotation of the IOL. So the severity of the power error is seen if ideal IOL cylinder power is more than halfway to the next available cylinder, step up or down. If it's yes, then consider the IOL exchange. And in post-operative keratometry, the calculated ideal IOL meridian should coincide with the post-operative steep axis. And when is the best timing for IOL rotation is not established by trials. It's logically done when some capsular shrinkage has occurred to avoid a further rotation. That is ideally between 2 to 4 weeks post-operatively. A later intervention usually is difficult because we are unable to free the IOL in a tightly adherent capsular bag. So we can consider CTR to expand the capsular equator. And then comes the concept of deliberate off-axis placement discussed in the article. So this is done in situation where we do not have an access to a low-powered IOL, but this is seen in non-peer reviewed literature. But this is totally a misunderstanding of the toric IOL optics. We should never do this deliberate off-axis placement because reducing the correcting effect of the cylinder in the IOL can leading to increasing and not decreasing the remaining astigmatism. And the toric IOL refractive outcome is dependent on a good preoperative measurement, which is absolutely vital, and a good IOL toric power calculation, and finally a good surgical technique, and also the successful use of a toric IOL in a patient. The least refractive astigmatism should be obtained post-operatively, which is achieved by adequate alignment of the IOL and adequate power selection. So to conclude, they're combining appropriate sphere power choice and accurate use of toric IOL will improve on the patient's pre-morbid state. And the accurate preoperative assessment, good calculation of the IOL cylinder power, including the surgical induced astigmatism and posterior corneal astigmatism, and a good surgical technique will lead to an excellent refractive results. So it is implanted in about 10 to 15% in most of the developed world and in up to 30% in Australia. So that shows that the percentage of patients having this pre-existing corneal astigmatism is on the higher side. And the limiting factor is definitely the cost, and this anomaly should be addressed.
Thank you, Dr. Neetu. Very well presented. Now I think we have all the mentors can join in as well as the discussants can join in the discussion. The discussion hopefully should be at the level of postgraduates.
Let me put some of the important things. This is a very important review article because toric IOLs are the standard of management for cataract surgery, and it should have included many things in that review. If you look into a PubMed publication only in toric IOL, there are almost 1,000 publications, and you have to pick up correct ones to highlight the actual advantage of toric IOL in various situations. And few things, they went through various aspects, nice introduction, then designs of lens, the calculation of toricity of cornea, anterior, posterior calculation, surgical aspects. So few things I like to add here. We can have a discussion on those also. One important thing which we need to highlight in any review is the importance of a posterior corneal curvature. They have rightly talked about that also. But one thing is missing, the age of a patient. You have a younger patient, you have older patients. We all know with the rule astigmatism, anterior will shift slowly to against the rule astigmatism. Suppose we are putting a toric IOL in a young patient, like a pediatric patient. How do we calculate that particular part? And what will happen after 15, 20 years or at age of 40 years? So that is the one important thing which is missing in this. Second is, they rightly pointed out the loop haptic lenses are better and stable. And a lot of comparative studies have been done in that. And I think one of the studies shows that Alcon Acrysop lenses, they have less than 4% chance of a rotation for more than 3 degrees. But see what changes people have made in recent time. One of the very significant study published by Dr. David Chang, where he worked on a Technis IOLs, and their lenses were rotating much more than Acrysop lenses. Design was same, a little modification onto the edge and haptic. They made a little textured haptic, and that made a significant change. So those things have not been highlighted, how the designs have modified in the last so many decades, which made the more stable ones. And you talked about visual acuity compared to manual marking and the digital marking or image guided. They said the visual acuity is almost similar, but then they never talked about the quality of vision. Because if you have lesser degree of rotation, your quality of vision is going to be better. It will decrease the higher order aberration. It will improve your MTF. That is what our study has proved. It was published in JCRS long time back. where we compared the manual versus the digital marking, we found that the MTF was much better. Stress ratio and MTF much better with the digital or image guided systems. So that they didn't highlight the quality of vision because we are looking for a quality of vision. We're not looking for a visual acuity. So that should have been highlighted in this particular study. For a younger generation, that is more important nowadays. We don't talk about acuity nowadays. We talk about quality of vision for every patient because cataract surgery is like refractive surgery now. People demand so much. And other important thing is, use of aura. Aura came with a bang, but it did not really fulfill the requirements as far we are concerned. We have aura, multiples of them in our RP center, but whatever we could do it really did not support that much, except for a few cases of post refractive surgery or post RK. One or two cases we presented post refractive surgery surprises that might work. Otherwise, it's not really helpful in modifying or improving your outcome with the modern technology we have for a toric lens implantation in these cases. Third important thing which I like to highlight is the post-op rotation. There are 2 or 3 ways to look into. One is rotation happening because of your back or IOL disparity. That's a different issue. That may be myopia, that may be a post-refractive surgery patient or a very deep chamber keratoconic eyes. Second, the rotation happening because of maybe your lens was misplaced, your marking was not accurate, or you had some other things. If you feel your marking was not accurate, you should not wait for 2-3 weeks to capsule to get fibrous, because we know that within a week or so, the haptic optic junction gets attached to the capsule and it forms a memory. If I rotate again, the lens will come to same area. If it is because of axis misplacement, then it should be rotated as quickly as possible so that you correct it. But if it is because of a capsule, bag, and IOL disorientation or mismatch, then maybe yes, you might wait for some time to let the bag shrink and then you put it. That they should have highlighted that important point also. I think one important thing is, SIA is not a significant point discussion nowadays. We have hardly discussed SIA nowadays with the incision size that come down. Rather than talking of ACC, other things, large incision, that concept is gone. Second is, I think there's not much article comparing, hydro implantation and a visco implantation nowadays. People are shifting towards a hydro implantation so that viscoelastic causing the rotation has decreased, because if you look into one Japanese study, they said whatever rotation happens, maximum happens within the first hour of surgery. And that may be mainly because of viscoelastic as such. But I think that debate should also be discussed in these areas also. I think this is a good recent article, but it doesn't cover many things for us postgraduate students, The other comments.
Thank you, Titial,
Yeah.
sir. Sir.
Dr. Jan,
Yeah, Dr. Reddy.
Reddy, sir, please.
Dr. Professor Trial sir said, one aspect always it bothers me is the astigmatism. Astigmatism is not a static phenomenon, it changes with the age.
Sir, can you be a bit louder, a bit close to the mic? Yeah.
Astigmatism is okay now?
Yes, sir.
Astigmatism is not a static one, it is a it moves with the age. So nowadays with this one Postoperative IOLs and all those, early we are operating patients much earlier, 50 years, 45 years, who will live for another 30, 40 years. So with the rule, astigmatism will keep on decreasing, and against the rule, astigmatism will keep on increasing. Then comes the problem. What we'll do after that? I feel the answer is after 10 years, we saw our own patient, 10, 15 years down the line coming, they increase the astigmatism. It started perfectly. Now it's added up another 0.75 or maybe 1 diopter. So that's the only answer. It looks like me like doing CRK again for them. Because you gave a multifocal IOL, then again ask them to wear spectacles after 10 years. It doesn't make much sense. So there is I don't think there is any calculated, I don't think, unless we freeze the cornea right, you do a cross-linking and freeze the cornea again. with the low dose, there is no way to stop that astigmatism shift. That's what I believe. Maybe it's beyond postgraduate thinking. Sir, what is your like?
There is a Bayer's nomogram where they look into with the rule and against the rule posterior corneal curvature, and age is also factored there. So that is a one calculator which looks into that. But how accurate that's going to go, we are not sure. Every patient may not go in the same manner,
Unless we know how to fit the cornea in the same
Yeah.
position until we fit the second thing is, you pointed out rightly about the rotation. I also believe that it should be corrected as soon as possible. Incomplete. The problem is coming only for us in post-refractive eyes. Basically, the eye looks 22 diopters power, but the eye is a myopic eye. Pre-diopter is not a large lens. When you are putting toric lenses, it can rotate those cases. See, 1 hour. What's your take on that, sir? See, 1 hour, they say most of the rotation I also read. So you keep the patient lying down for 1 hour in the room or 1 hour on the table. How do you manage?
I don't know who was that surgeon who was checking the patient at 1 hour. We hardly see patient at 1 hour. We normally see next day, and by the time everything settles down. And if something happens within a 1 hour, also who's going to take the patient back to OR and do things, So ultimately, I think the lens settles down, and that gives you an incentive for us to do a better management in the during the IOL manipulation. Remove the viscoelastic completely, let the lens open up. Sometimes I debate hydro implantation and visco implantation. I say do it visco implantation because to remove the viscoelastic takes time, and that time gives a lens to open up completely and be in a normal shape. So sometimes that is also important. If hydroimplanted lens keep moving and may not open up entirely into the normal position.
Dr. Venkatesh, Dr. Bhaumik.
So, yeah, now let us discuss in the monofocal IOL, that's the toric IOL, in case of multifocal IOL, toric IOL, or the trifocal toric IOL. What will be your standard correcting astigmatism? It is the same as we consider in the trifocal, just 0.75, 0.7 in ATR, or 1.2 is WTR. So now the days everyone wants to crisp vision. I think even the monofocal practice also, the threshold of the astigmatism coming like a trifocal IOL or multifocal IOL. And I am prescribing toric IOL even the patient having more than 0.775 ATR. As Dr. TTL sir can highlight, what should be the ideal, what should the target of astigmatism you should correct in the monofocal cases?
Yeah, Dr. Arup, I fully agree with whatever you said. I think today is a time where we have to correct the entire, range of refractive error, even for a monofocal IOS also. I go for even less than 1, I go for toric lenses. Because the aim is, there to give as sharp as possible distance vision for these patients, because they opted for getting a clear distance vision. And if you are left with a 0.5, 0.75 cylinder, the distance vision correction is not, they are not happy. So it has to be corrected fully if possible in these cases also. So I'll go for that. Not necessarily for a multifocal, for a monofocal also. It should be corrected as far as possible.
Another important aspect is when you are doing the calculator you are using, if you using Barrett Universal 2 and consider corneal astigmatism, anterior corneal astigmatism, you calculate in the Barrett calculator. But when you are using TK, total astigmatism, you have to calculate in the TK calculator. Otherwise, your posterior corneal astigmatism considers it twice. This is a very important factor that is not mentioned here, that review. Because if you consider the total keratometry, TK, then you have to calculate your toric IOL in that Barrett TK calculator. Toric calculator, not in the conventional Toric calculator. Because if you consider TK and calculate in the Barrev calculator, you are considering the posterior corneal astigmatism twice. In that case, you can overcorrecting the ATR and undercorrecting the WTR. So this is another issue I thought that I should mention, because this is not mentioning in this literature review.
Yes, absolutely fine. Correct.
Venkatesh, sir.
Yeah, just finally, I'm also learning in this discussion. I mean, it's interesting. I think any review article cannot cover every aspect of what we are talking. I'm sure there will be some limitations, and that opens up the box that you can write more review articles on this. No, but I think Professor Titial beautifully highlighted how the utility is so important now. No, you have to really see how patients benefit from all this. And there are several studies which have proven the cost effectiveness of using these lenses, and also how patients benefit from these. No, but again, it needs a separate paper to deal with. But this particular paper, I think they're just looking at how you can do a better placement, or the importance of marking and things like that. Neetu did a very good presentation, but I think Neetu, as a resident, I mean, I would like to emphasize that you can make this a brilliant presentation. It may be a regular topic like this, but you can make it interesting. So there are a few things which I would like to highlight in your presentation, because most of the scientific discussion has already happened. One thing is the title case. Now, how you use is very important. Now, try to avoid everything to be in bold. And also the color pattern is very important. Now, how do you want to use and what colors you want to use in a PowerPoint? And whenever you do an article like this, you read multiple times so that you can reduce the number of words in those sentences, so that the content is very clear to people who are seeing. And then, of course, using images which you used, and unfortunately you had to jump in some of those images, especially the plate haptic and loop haptic and all that, which is very important for audience to see how it is going to stay in the back. So wherein, and you showed a beautiful videos of the surgery done, which is also equally important. But I think the focus as a resident, the content is important, and the way you're going to take this content to the audience and make it interesting is also important. So that's a small piece of advice I would like to give. Yeah.
Just one point, I agree to Dr. Venkatesh. Like what we do in a teaching institution like ours, the resident who's presenting the article, it's not that only the article you have to read the other articles also. So you make a judgment. It is, beneficial or not beneficial. Does it have an importance or not? Which would have been, how it could have been improved? What was the methodology? Was it better, or it could have been better? Or you could make your own conclusion. Suppose you talk about what I talked about initially, that should have been brought up by you. You said this article says this, but this should have been like this. There are other studies which have given like this. So that is how you do your own review for each article. It's not only for presentation. Though we have a discussion here, for people like, who's going to make a presentation, they have to give their own, review for each point. So that will make you, completely aware of an entire gamut of Toric IOL. So reading article is reading everything. You could have given your own conclusion to us end. Okay, I appreciate this was better. This was missing. This could have been included. This would have been removed. Something like that. So that will make a very nice reading for others also. So you should make a note now, go back, read the other articles and put a note. Maybe you can put into the ARC group like this could have been better like this.
Thank you.
So you can write an article right from here. That is what Professor is saying. No, because there is nothing actually in this article, but he was able to get it into clinical and experimental ophthalmology, right? I mean, there's absolutely nothing here. So it is just a review of whatever has happened so far in the last 5-10 years. By the time this article gets published, the technology changes. That's what we have seen. This is 22 and 23. Now you are in a different way of doing toric lens, or different the way of the capsule adherence to the lens optics and all that. No, it changes so quickly. So all this gives you an idea. Like Professor says, it's the SWOT analysis. No, you have to look at the strength, weakness, and what opportunity you have from this article to write even a better review article. And no, that is how, as residents, if you start seeing, then you will learn a lot from these discussions, and also you will take it forward to a next level as a researcher.
Yes, correct.
Yes.
Thank you. Thank you, Venkatesh sir, Dr. Titial sir. Dr. Neetu, you of course presented absolutely brilliantly, but these are the ways how you can improvise. And exactly from a SWOT analysis, you get an opportunity how to excel and how to start writing a paper for yourself. So very well given piece of advice, not only for Neetu, but all the postgraduates who are watching us and are going to watch this particular series. So now, thank you once more, Dr. Neetu, and the mentors, proud mentors, Dr. Prabhu and Dr. JK sir. So now it's time for us to move to the second article, and it will be presented by Dr. Abhijay Luthra, who is a DNB resident at Shroff Charity Eye Center, and his proud mentors are Dr. Shalinder Sabarwal and Dr. Judy Peg. Please, you can share your screen, Doctor.
Good evening. 1 second, I'll just share my screen. I hope my screen is visible, sir.
Yes, yes, you are adequately heard as well. And go ahead.
Good evening, one and all. I'd like to start by thanking ARC and Dr. Prashant for giving me this opportunity to present, and also all the esteemed consultants and my mentors, Dr. Shalinder and Dr. Julie, who have joined in for the discussion. So the article I'll be presenting on is intracameral dexamethasone 9% versus prednisolone acetate 1% in controlling postoperative pain and inflammation in patients undergoing cataract surgery. The authors are Dr. John Hovhanessian and Dr. Eric Donefeld. This was published in the Journal of Cataract and Refractive Surgery in August 2022. The study was conducted in 2 hospitals, Harvard Eye Associates and Ophthalmic Consultants of Long Island, New York. 1 second. Yeah. So the Journal of Cataract and Refractive Surgery is the official journal of the ASCRS and the ESCRS, and it had an impact factor of 2.8 in 2022. So traditionally, cataract surgery, which is the most commonly performed ophthalmic surgery worldwide, mandates inflammation and pain management, and the traditional topical postoperative management consists of topical antibiotics, corticosteroids, and NSAIDs. In a study by Walters et al., they found that patients who do not receive any treatment post-cataract surgery, around 70 to 85% show AC cells, 50 to 65% show AC flare, and 40 to 60% experience pain. So post-cataract surgery management is necessary. But is the traditional way really the best way? Let's look at some of the problems that we encounter with this. When we go with topical drug preparations, we have poor bioavailability with variable drug concentration over time. There are undesired peaks and troughs according to the time of administration of the drop. In a study by Shell et al., they found that topical drug administration may lose up to 90% of their active component after 30 seconds, depending on the method of administration. There may be improper drug administration techniques, and et al. Found that 93% of patients have improper drug administration techniques if they are not taught well, and multiple dosing regimens lead to poor compliance in patients. So what are the alternative approaches that we can use instead of the traditional topical management? We have the intracameral route, which we'll be discussing further on. We have the posterior subtenance route, and we have the intracanalicular route, which is a fairly new route that is being used in the form of a Dextenza implant for post-cataract inflammation management. So this is where Dexisu, which is our intracameral implant, comes in. It's a dexamethasone intraocular suspension 9%, which is formulated in a volume of 0.005 ml. It's delivered into the posterior chamber inferiorly behind the iris at the end of the surgery. And it uses the Verisome technology to provide a high initial release of the drug, followed by a gradual tapering over the next 1 month. It contains a total of 517 micrograms of dexamethasone, and once injected, it forms a 2 millimeter spedule behind the iris, which consists of the active drug suspended in a delivery vehicle of acetyl triethyl citrate. As can be seen in the photo, it's once the IOL has been implanted and the chamber has been formed, we inject it using a special injector behind the iris. So coming to the article now, the purpose of the study, the primary outcome that we wanted to check was to evaluate patient preference of a post-cataract surgery drug regimen that minimizes post-operative topical medication use compared with routine post-operative topical therapy treatment in the fellow eye. So this was a subjective outcome that was being studied. And the secondary outcomes, which were more objective in nature, were evaluating the ocular pain and inflammation scores, out-of-pocket medication costs, and the effect on the final best corrected visual acuity between the two drug regimens. So we'll be discussing this study using the MARI framework for study assessment, which consists of 6 steps in which the study is assessed: the methodology, the assignment, the assessment, results, interpretation, and extrapolation. Starting with the methodology, this study was a post-approval, open-label, randomized, self-controlled, prospective study. Post-approval meaning that it was conducted once the drug had gained approval from the FDA, and open-label meaning that all the investigators and the patients knew that they were a part of the study and were aware of each of the regimens that they were being put through. The other 3 are self-explanatory, I believe. The sample size was 60 eyes of 30 patients undergoing routine cataract surgery, which was calculated using the RAWSoft online sample size calculator using a 5% margin of error and 95% confidence levels for the primary outcome measure. The inclusion criteria was patients with visually significant cataract requiring phacoemulsification and IOL implantation, and all patients with any signs of intraocular inflammation, known steroid responders, retinal disorders, having undergone a previous surgery, recurrent inflammatory disease, ocular inflammation or pain, sensitivity to medications, guarded visual prognosis, capsular abnormalities, pupillary abnormalities, uncontrolled glaucoma, and poorly controlled diabetics were excluded from the study. The study, prior to beginning, gained ethical approval. It adhered to the tenets of the Declaration of Helsinki and good clinical practices, which are defined by the US Food and Drug Administration. And IRB approval was gained from the WCG IRB Society in Pune and the FDA Investigational New Drug Application. Coming on to the assignment of patients, all eyes undergoing surgery using a randomization key were randomized either into the dexamethasone suspension regimen or the prednisolone acetate regimen, and the second eye would consequently receive the opposite treatment when it was operated. So the 1 drop, there were 2 regimens that were made, the 1 drop and the 3 drop. The 1 drop was the one with intracameral dexamethasone and intracameral moxifloxacin being administered at the end of the surgery. And only 1 topical medication was used, that was bromfenac and NSAID, that was started 1 day before the surgery and continued till 4 weeks in a QID dosing. And the other topical regimen consisted of prednisolone acetate 1%, QID first for 2 weeks post-operative, and BD for 2 weeks post-operative. Moxifloxacin and bromfenac were both started 1 day before the surgery. Moxi was continued in a QID dosing up to the first 10 days post-operative, and bromfenac in a QID dosing for up to 4 weeks post-operative. Coming to how the outcomes would be assessed, the primary outcome measure was evaluated using the COMTOL questionnaire, which stands for Comparison of Ophthalmic Medical.
Can I interrupt here?
Yes, sir. Of course.
Achha. Let's come to the basic point. Are you happy? All the mentors also. Are you happy with the PARO study? How have they calculated the sample size?
So it's been calculated using basically it's an online sample size calculator in which you put in that how much margin of error you are ready to accept. And then also they had conducted a trial of a different set of patients, asking them how many of them would prefer a 1-drop regimen versus a 3-drop regimen.
That is the questionable issue, because they have taken 30 patients. No?
Yes, sir.
Per patient, how much the number? 30 patients is
30 patients,
60
eyes, sir.
Only 60 eyes and 30 patients. And presuming that they have already presumed that intracameral drug is going to be better choice than other ones. Based on that, they calculated 95% confidence, and which I suspect is not a good way to calculate. If you look into a cataract patient going through these type of surgeries, the sample size should have been bigger. Because 30 patients, you may not have the people having the other problems. That was one question. Second was, are you okay with the type of study they have designed? Because they have Like one group, they are giving a topical medication, which is steroids, combination of steroid and bromphenic in one group. Other group, they are giving bromphenic and the intracameral steroid depot. And this steroid going to last for how many days?
So up to a month, sir. The effect stays for a month, 4 weeks.
Nobody knows. No, they have not done study to see what is the concentration
No, sir,
of
not.
steroid. Yeah,
No, sir. No, sir.
Yeah, and third, there should have been a third group also. If they don't have a third eye, but there should have a third group. Maybe it was only the bromphenic which was giving good results in these cases where they are not using the prednisolone. You understand that point?
Yes, sir. So these both, yes, sir.
Yeah, other thing which is little contrasting is, these studies, okay, the surgeon and patient cannot be blinded, but the evaluator could have been blinded here. Somebody who's assessing the patient in terms of the post-op information, pain, score, everything, he or she could have been blinded. That would have given the actual results. It is the same group of people doing surgery and same group of people assessing these patients.
Yes, sir.
Abhijay, when was the second eye done? When was the second eye done?
Sir, the second eye was operated at a mean of 12 days after the first eye, sir.
After?
So 12 days after the first eye, in some patients around 10 days, in some patients up to 20 days after the first eye.
That was also
the mean gap was 12 days, sir.
And that 12 days is quite less, and suppose the patient is on a prednisolone drop other eye, and that effect will go to other side also.
Yeah.
And there's no washout period in these cases. So that is a little this thing.
No, it'll be one eye you are using 3 medications and the other eye you are asked to put 1 medication. All that will cause confusion to the patient also in the post-operative protocol. Unless he completes one term and then he goes to the other eye, then it's absolutely fine. There are a lot of interesting things. Yeah.
Okay. I believe all of these come into the limitations of the study. So first of all, that the sample size was really small. And being an open label study, especially doing both the eyes of the same patient and giving 2 regimens for each different eye would obviously introduce a bias into the patient, because the patient, irrespective of how the pain would be, would obviously prefer the 1-drop regimen since he's undergoing both at the same time. These are both limitations of the study, sir.
Yeah, Abhijay is absolutely correct. Okay, let's go on.
So moving on to the primary outcome measure, it was assessed using the comparison of ophthalmic medications for tolerability questionnaire, which is a validated questionnaire published by Baba et al. In 1997. It was designed to capture the frequency and bother of common side effects of topical drugs, the extent to which these side effects and any associated limitations in routine living activities interfere with the patient's health-related quality of life, their compliance with the medication, and their satisfaction with the medication. This questionnaire was administered twice during the post-operative period of each eye to the patient. First after 2 weeks of the medication, and again after the next 2 weeks, that is at 4 weeks post-operative for each eye. This would be an overlap between the 2 eyes. So coming to the secondary outcome measures that were calculated, out-of-pocket medication cost and post-operative pain were assessed for by adding questions to the end of the same questionnaire. The summed ocular inflammation score was calculated at 7, 14, and 28 days. This basically stands for, it's a score in which a certified ophthalmologist assesses the patient on a slit lamp and grades the AC cells and the AC flare on a grade of 0 to +4. And then both of them are added, and that gives us the summed ocular inflammation score. Visual outcomes, IOP and macular thickness were assessed at day 20, throughout the postoperative period. Self-reported drug compliance was asked for at 14 days by asking the patient how often did you miss 1 or more doses. Activity interference for each eye was assessed at 14 days post-operative by asking a group of 5 questions for the patient, which we'll go into further detail later in the result. And in the end, an overall satisfaction grading was asked by the patient for each eye drop regimen for each eye. Moving on to the results, the study was completed by 29 patients. There was 1 dropout who could not follow up in the post-operative period completely, so was excluded. The mean age of the patients was 74 plus minus 6.3 years, and 62% first eyes were randomized to receive the 1-drop regimen first. The mean interval between the first and the second eye surgery was 12.6 plus minus 4.2 days. 62% of the population was female and 38% were males. The baseline evaluations that were done before the surgery did not have any statistically significant differences when it came to the corrected distance visual acuity, the intraocular pressure, the summed ocular inflammatory score, the grading of the cataract, and the macular thickness, which were assessed preoperatively. Coming to the primary outcome measures result, it was found that out of the 29 patients, 28 patients, that is 97%, said they preferred the one-drop regimen. And there was only one patient who said he preferred the three-drop regimen. This had a statistically significant difference with a p-value of less than 0.001 according to the McNamara test of paired proportion. And when it comes to the reasons that were given by the patients as to why they preferred the one-drop regimen, 11 said one drop was easier, 5 said there was nothing to remember, and one patient specified that the out-of-pocket cost was less for the one-drop regimen compared to the three-drop regimen. The only patient who preferred the three-drop regimen said that was because it made his eyes moister. Coming to the secondary outcomes of the study, first of all, the medication out-of-pocket cost for the one-drop regimen, it was found to be $40.9 plus minus 65.6, and for the three-drop regimen, $139.2 plus minus 69.10. This comparison had a statistically significant difference with a p-value of less than 0.0004 using the t-test for paired sample. Coming to the post-operative pain assessed by the patient.
Dr. Abhijay,
Yes, sir.
that means that intracameral steroid was included into a cost of surgery, no?
So that is another limitation that for a lot of patients, it was covered by the insurance, and for a few patients, it was not. That is a bias that is in the study.
Yeah, this is a totally biased type of study for us, because in US, the post-op treatment is not covered, and that's why expense goes to the patient. So nobody will prefer this, In India, it will be reverse because the intracameral drug will be costlier than the topical medications.
Yes, I have included that in the limitations.
Yeah.
So coming to the post-operative pain, the patients were asked to grade the pain at 14 days post-operatively on a scale of 1 to 10. And on comparison, only 4% of patients reported severe pain from the one-drop regimen compared to 12% from the three-drop regimen. And 57% patients from the one-drop regimen reported no pain, whereas it was only 27% in the three-drop regimen. Coming to the next secondary outcome, that is summed ocular inflammatory score. It was a mean of 0.53 for the one-drop regimen patients and 0.92 for the three-drop regimen patients. This was also a statistically significant difference between the two regimens with a p-value of less than 0.002. IOP was also compared between the two groups at day 7, day 14, and day 28, but no statistically significant difference was found. There were also no statistically significant differences in the macular thickness assessed using OCT at 28 days post-operative and in the residual refraction at 28 days post-operative. Visual acuity, when assessed, it was found that there was significantly more eyes on POD1. And this also goes the same for POD 7, 14, and 28, that all the patients in the one-drop regimen had a better uncorrected distance visual acuity compared to the patients with the three-drop regimen. But when it comes to the corrected distance visual acuity, then there were no statistically significant differences between both the groups at post-operative day 28. So as we can see, there were a larger number of patients who presented with a better visual acuity at all of these stages with the one-drop regimen. Coming to the secondary outcomes, when it comes to drop compliance in the one-drop regimen, 100% of patients stated that they did not miss any doses. Whereas in the three-drop regimen, only 34% said that they did not miss any doses, whereas 38% accepted that they missed the doses a few times. So there was a statistically significant difference in drop compliance between the two groups with a value of less than 0.0001 using the chi-square test. The next outcome assessed was activity interference, which again showed statistically significant differences. These 5 questions were asked to the patient at postoperative day 14. How much interference were they facing with each of the drop regimens, with driving at night, driving during daylight, climbing one flight of stairs, reading the newspaper, and reading anything else. So it was only the same for climbing one flight of stairs. In all the others, the one drop regimen patients had less interference. And the third, overall satisfaction. In the one drop regimen, 92% of patients said that they were totally satisfied with the post-op treatment, compared to only 8% in the three drop regimen. Moving on to the interpretation, what this study gives us, it tells us that most of the patients preferred a one drop regimen compared to the three drop regimen post-operatively. A statistically significant number of patients in the one drop regimen group had a better uncorrected distance visual acuity at all follow-up time points compared to the three drop, but this did not actually affect the corrected distance visual acuity in the long term. The one drop regimen patients reported less activity interference than the three drop regimen patients. Some ocular inflammatory score was also less in the one drop regimen patient. More pain was reported for the eye in the patients in the three drop regimen. And finally, it showed that patients, when it comes to compliance, they were fully compliant when it came to the one drop regimen, but compliance was decreased with the three drop regimen. So coming to the extrapolation from the study, since the study concentrated on patients in two different geographic regions, out-of-pocket expenditure may have pricing differences. Also, if this were replicated in the Indian scenario, it may show varied results with respect to affordability and compliance. Since out-of-pocket cost may be more for patients who are getting the implant, it would not be covered by the insurance. Like most of the patients here do not opt for insurance and are usually paying out of their own pocket. And efficacy of intracameral administration should be avoided in patients with glaucoma or history of steroid response, as was done by the study. But it might be possible to study in patients with chronic inflammatory disorders in whom sometimes the topical management is not very effective in controlling the post-operative inflammation. The limitations of the study, which I found, are that it has a small sample size. We may have missed incidence of positive effects. Does not quantify and compare based on the objective assessment of inflammation control. We are not grading, we are only using a summed ocular inflammatory score, and no other objective findings are being looked for during the examination. It does not take into consideration what we might do in case the patient turns out to be a steroid responder. If we're using a topical approach, then we can immediately decrease the amount of steroids that we are giving. But if we put an intracameral implant, I don't believe there is any, as of yet mentioned, way that it can be removed. It does not take into consideration the patient bias when the patient knows that they are using two different regimens and what in each different eye. This is known as the Hawthorne bias, in which the patient is not blinded. The patient is aware of the study being conducted on him, and that introduces a bias in the patient. Again, as you mentioned, the out-of-pocket medication costs may be limited by insurance. And also, we do not exactly know what all questions have been asked as part of the COMTOL questionnaire. It has not been provided as part of the article, and it is not a free access questionnaire. Next, I would like to mention the benefits of going with the randomized controlled trial approach. So when we come to a validity of the types of studies that can be conducted, right after systematic review, which is a meta-analysis of a lot of trials, the next, we have randomized controlled trial, which is considered as the gold standard for evaluating the effectiveness of interventions. And all cohort, case control studies, case series, and case reports are less valid than a randomized controlled trial. It prevents selection bias and also takes care of unknown confounding factors. And the review of literature that I have studied with regards to this consists of that in 2004, in a study conducted by Afzal C. Wadood et al. They studied the comparison of AC flare in post-cataract surgery patients treated with the intracameral Surotex implant versus topical dexamethasone drops, and both were found to be equally effective with a similar safety profile. Kiernan et al. In 2020 studied on the use of the Dexisu suspension placement into the anterior chamber after VR surgery, and found that it was more effective than topical steroids in treating inflammation occurring 1 week following VR surgery. And Erickson et al. In 2021 studied the comparison of postoperative inflammation in post-cataract surgery patients receiving the standard topical steroid regimen versus 0.5 ml of 4 mg per ml dexamethasone subtenon depot. And in this, it was found that the droplet group of patients had a significantly increased postoperative inflammation. So most certainly using the Dexisu, we have progressed. It's giving us better results compared to the subtenon use of steroids. And that will be all from my side. Thank you so much.
The mentors can add to it, and then we can have a discussion.
First, I'd like to say, Good job done by mentors here.
Yeah.
Salinder and Julie, you have done a good job.
Thank you,
And,
sir.
actually, it's a very nice presentation, Vijay did a wonderful job. Yeah, carry on.
Yeah, I just wanted to add, I think what sir has already said. Sometimes when you read a RCT, you say, okay, this is a perfect study. So you have to look into the fact light from the sample size. So sample size statistically has been done right. But if you look at it, suppose we say the obvious thing in this study would be that if I tell one patient to put 1 drop versus 3 drop, obviously the 1 drop person would be happier. Anyway, any day, if you say no drop, they'll be even more happy, right? So that is easy. But the fact is, if you're measuring the other things of inflammation and let's say the pain and all, that doesn't fit in somehow. And the sample size could have been calculated according to that. What is the probability of having inflammation after post-op? Because so many patients miss their steroids, but don't get inflammation. We know that in phaco anyway. And second thing that which is not understandable easily is that if they were going for less drops, why didn't they not go for no drop? And why did they still continue with 1 drop? That is very difficult to explain in the methods of the study. And I think more or less what they're trying to say is it is better, but some of the things don't match up. Like we were discussing the other day, if an uneventful surgery, why would about 30-40% patient complained of moderate to severe pain, which is in one group, which is again not explainable because unless the questionnaire which we couldn't get hold of is so vague that somebody is saying pain is equal to discomfort or some irritation, that is not very clear. Because the data shows in their study that about 30% complained of severe or moderate pain, and that is not common for cataract patients which have who have undergone an uneventful surgery. So that is what I wanted to say. Thanks.
I think one very important point is this study is from US, and ethnicity would be a very important factor here. The same thing, you do surgery in other races will have more inflammation. People, Caucasians have a lesser inflammation. So maybe no drop, 1 drop will suffice. In scenario like, with the pigmented eyes, things will be totally different. And we do use cycloplegic, if not for a entire duration, most of us use cycloplegic for at least for a week. I'm not sure what is the practice with other people also. I do use for 2 weeks. First week I use twice a day, and next week I use once a day, and then put it off. But I agree to Salinder, why not, no drop in those cases where you put an implant inside it. If you feel inflammation is the only thing to be seen, then your sample size would have been a very, very big. To pick up an inflammation, compare it should be thousands of patients. They are very smart. They've taken a one clue that, okay, they have done a pilot study and it shows that it is beneficial. And 95% people have chosen that, regime beforehand. Looking to that, they had a 30 sample size, which is totally not acceptable in a good quality paper as such, research wise. Other important thing, as you rightly pointed out, I think Abhijay pointed out that it's not if you look into actual inflammation, then you have to measure the cells and flare absolutely correctly, which they have done in a slit lamp, which can be misled some, though it is done by experienced person. But if you have cell flare meter, that would have given a better justice to these people, And other thing, they have not. I'm surprised. How can one group have the lesser visual acuity, other group has a better visual acuity? It doesn't relate to, and they had almost no difference in the inflammation per se. That means either they had some sort of astigmatism remaining those patients, and maybe these patients had more harder cataract or softer cataract, or they had a pre-existing cylinder, which they had not talked about. It cannot be correlated with the type of regime they have used.
Yes, sir, we completely agree with you, Abhijay. Wonderful presentation. And thank you for making it so elaborate and following the medical protocol. even we were not comfortable with the open label part of the study because, like Sir had mentioned, that the evaluator could have been blinded. That could have added more robustness to the study. And obviously, because the two surgeries were done like within a gap of maybe 12 to 15 days, so there could have been a drug overlap and drug, affecting the other eye as well. So the vision part, even we couldn't understand why in an uneventful cataract surgery with the surgeon being the same for both the eyes, why would one have a good vision and the second eye would not have a good vision? Because if one eye had a cylinder, most likely the other eye would have also have a cylinder. So I think these are the biases, and the other biases have already been discussed. And I think another thing is that 62% of the patients receive the 1-drop regimen versus 48 in the 3-drop regimen. I don't know why that was also done.
That means, that contralateral eye was not, correctly done. It has a lot of loopholes, That's why it's published in a, paid journal.
And so I was very uncomfortable with the feeling that you leave an implant in the eye. If the patient turns out to be a steroid responder, it would cause such devastating complication like something like a glaucoma. So that was one thing I was very uncomfortable with because they only ruled out uncontrollable glaucoma, but anybody could have been treatment naive.
Dr. Venkatesh, Dr. Bhaumik, Dr. JK, you can also add to it discussion.
This study don't use anything those who can reduce the biasness. I think there is a lot of biasness in this study in different aspect that could be biased. So the sample size is very small, and that's everyone is talking about that the uncorrected visual acuity is different. And that is what is very surprising to me, that the uneventful phaco surgery, why the number of patient having the pain. The most of the even in our highly dark iris in our Indian cases, we don't patient doesn't have complain of lot of this number of patient, even this percentage of number not complaining of pain in even our cases. So that is very surprising. The number of pain patient is complaining even in 3-drug regime. And definitely the uncorrected visual acuity is a different, where the corrected visual acuity is same. That is significant. That is not related to at all with the drug regime.
I think it has one important message. If that holds true, like one intracameral injection can suffice the entire period of 4 to 6 weeks of a controlling inflammation, then it would be a wonderful way of treating our patient in India. Our patient come from a very far off place. You give one intracameral and they go off and don't come back. If that happens, it will be a very nice way to treat our patients. That
I totally agree.
Some positive thing, but I'm not sure it's going to be absolutely correct.
In fact, coming back to the out-of-pocket expense, if you look at some of the organization, even AIMS and us, we're doing a lot of free surgeries. And somehow if the cost can be built into that, and if this really works, and we all know that even sometimes access to good quality medicine is difficult for patients who are coming from very remote areas. So it could be a good thing. There are some studies which are actually highlighting the 0-drop surgeries also now. But I think what is a good message from here is that methods have to be looked into and not just the study design. So that should be really looked into.
Yeah, it does have a one positive aspect. If that can be, controllable, and you have a sustained release covering for at least 4 to 6 weeks, then it's a wonderful way to look into our patients.
There is one study, sir, I didn't remember. There's a transjonular Kenacort in cases of cataract surgery. There is a study, and there is a no-drop study. That case also, the patient having that's a transjonular Kenacort, basically intravitreal Kenacort is actually controlling the inflammation postoperative routine cataract. And that study was also very promising. So in that case, if there is a one implant which takes care of all post-operative pain and inflammation. That will be wonderful. But I think that's a similar study will come up with a larger sample size.
Yeah, Arup, you are absolutely correct. I met this surgeon and I asked one question only.
Yeah.
As what will be those patients where you have an uncontrollable steroid responder glaucoma in these cases? You can't remove that translumin which you've injected in the vitreous cavity. So that is a major concern. And the immediate pressure rise which can happen in the vitreous body. A small injection can also increase the pressure immediately. So those are challenges. But I strongly feel intracameral pellet injection may be a better choice. That can be taken off also if you have a uncontrollable glaucoma can be taken off. But yes, futuristic way, it is a good way to look into, some sort of sustained release medication which doesn't disrupt the visual acuity or the intraocular lens posterior capsular relationship, because ultimately we are looking for a posterior capsule to get nearer to the posterior surface of the IOL in most cases. And if something which is inside the bag, it can always disrupt this alignment. And if it is can cause the local area of inflammation induced by that implant itself. Yes, I think there'll be something coming out in future also. But just now, it is the a group of people in US who are not very happy with the insurance not covering the post-op treatment for their patient. That's why they all look for these areas.
Venkatesh, your comments.
Yeah, Abhijay was a very good presentation. I think you are
This is an excellent presentation.
Excellent. The limitation, you nailed all the points. So I think I was just looking for if there is any letter to the editor. So after case series and your case reports, I think letter to editor is also equally important. So this is one way I think you can start your publication. Because you have done all these work, you can write this and see if JCRS accepts these limitations, because we have to tell the world that no, it's a okay study, but it's not a universally applicable study. No, you can't say that this will work everywhere for all the reasons we discussed now. Steroid response, the risk of infection, and all that we have to keep in mind. But we are always aiming at going for dropless or lesser drops. Because I am into sustainability, it also reduces the carbon footprint. If using 3 medications and throwing, and how things are being thrown off, at least in the Western world, where they are also looking at environmental sustainability. So the lesser the drops is always better, but we should have an ideal way of doing it. And there's a lot of work going on, even things which are being fixed to haptic and optic, which slowly releases. I think there is a bright future for that. But this particular paper, for all the limitations we discussed and you beautifully highlighted, it's worth writing a letter to the editor.
Vijay, if you write the letter, to the editor, you must give a credit to ARC, because this was discussed in the ARC group. I think, one thing is very important for our people to understand, those people who are listening to us. This study talks about only for inflammation post-cataract surgery. We in India or developing countries, we are worried about other area also, which is infection. And we'd like to cover the infection part also. They have totally disregarded the anti-infective medication. India, you can't leave patient without antibiotics. You might leave it, but your legal thing will catch you there. So, which is also a very important point. We have to look into that aspect also. It's not only the steroid, it is the anti-infective medication also very important. Maybe prophylactic, but we can't avoid that.
Thank you. Thank you, sir, for those wonderful suggestions from all the mentors and as well as from the discussant. I think it was a very thought-provoking discussion and a lot of learning behind it. We really exceeded the time, but yes, it was quite informative and quite, gaining in our information. So it's time for us to now wind it up. It was a great presentation, both of you, Dr. Neetu and Dr. Abhijay. You have done a wonderful job. Yes, how you can improvise and become a better presenter, as well as how you can initiate your research is what Dr. Venkatesh has also research, rather than research is publication part. He has given you an idea to both of you how you can initiate that part. And so this particular episode should be an ideas for your starting that itch to write. Okay. And once you get an itch to write, then you will never stop. Okay. So this is what Dr. Venkatesh
Don't
meant.
use chat GPT. No, that's
Yeah.
something I'll give you right away. Once you start doing that, then that itch to write will not come.
Prashant, I have one suggestion.
Yes, sir.
You're doing so many, PG programs now. Can you include one session of, discussion of the research paper published by the PGs?
Okay. Done, sir. We will have it. We will have
That will
it.
give and you award them also the best. We can have discussion on that. That will give a real incentive to these people to come forward. You ask for a thesis submissions. That's okay. That's part of this thing. Apart from that, have they published something? That will be the good one to discuss.
No, that's a great idea, Prashant. You can just say, you can give maybe a submission where whoever has published their thesis in the last 5 years to submit, and then you can select for the presentation.
The thesis they are doing in AI, they are doing. We do in AIMS, we have it's open for everybody in AIMS. For a student, scientist, faculty, we give the excellence award every year.
No, I'm just saying who have published their thesis.
Yeah.
Who have published their thesis in a good, then they have to submit for this competition.
Yeah.
That's a great thought, sir. We will definitely look into it and definitely will come back within few months. Once we are ready with we'll take some inputs from you, of course, and then we'll formulate how we can do to the best of the things, and we'll definitely do it. So, Dr. Neetu and Dr. Abhijay, thank you once more. You are really bold for your age, and you really did wonderful job. And get inspired by this and take it to a next level is what all the mentors and the discussant want you to do. My sincere thanks to both the mentors of both the places, Dr. JK and Dr. Prabhu Shankar, and Dr. Shalinder sir and Dr. Julie for wonderfully guiding their students so well. And of course, to all the senior discussants like Dr. Venkatesh, Titiyal sir, and Dr. Bhaumik for sparing time for our young Turks. So once more, it's my time for us to say bye. And once more, a sincere most thanks to all the discussants and mentors for coming and sparing their valuable time. Thank you.